Thank you so much. It's such a pleasure. I mean, you don't get such a full room very often. So thanks for coming at such a late time. And I'm really looking forward to present to you my view, medicine as a science. As Professor Vidimski said, my home institution is University Medical Center Ljubljana. I'm also teaching at medical school. And I also work in a heart center, another heart center, as a part-time job where I mainly do interventional cardiology. So this is my profile, my medical profile. So interventional cardiology, that means that we are trying to put stents and valves, etc., through the vessel instead of open heart surgery. So instead of opening the chest, we are trying to fix the problem through the vessel. And I'm also involved in acute cardiac care. Acute cardiac care means that we are taking care of patients with acute myocardial infarction, sudden cardiac arrest, acute heart failure. So in general, in cardiac patients who would die without immediate intervention. So this is actually what I do for my life. Of course, I do quite a lot of research work. And I will try to convince you that research can be really fun and it should become an essential part of your education already in the medical school. That's my task today. So hopefully, by the end of this lecture, I might convince you, most of you. And I do also teaching of medical students. It's always fun. It's always fun. I learn so much from them every time. Certain things you don't see, a student tells you. And when you're even 60 years old, he always tells you something new. And it's always so important for us to be in touch with your new generation, because new ideas, new communication, etc., are coming up. So what is my aim today, besides convincing you that you should become a researcher already as a medical student? Well, I would first like to discuss with you what is important in medical school. Because you're in medical school, you're first, second year, maybe third year. So I want to outline my experience, and maybe this can help you for your future career. I will also discuss how to choose a specialty after you finish your medical school. And again, role of research and science in medicine. And since I'm 60 almost, what really matters when I look back. And I will try to highlight these points through the story of my professional career. So when I was young, I always wanted to be a physician. The only competitor when I was 5 years old was fireman. But after that, it was only physician. When I was older, I had another problem, because I was also a professional downhill skier in a national team which was preparing for the '94 Olympics in Sarajevo. This is former Yugoslavia. You're younger, you haven't met this country probably. So anyway, of course, medicine, to study medicine and to do professional downhill competition didn't go together. But this problem was actually solved by itself, because in 1981, during my Europa Cup downhill race in Innsbruck in Austria, I got severe knee injury, which actually sent me to the medical school, because with that injury, there was no way I could continue professional skier. So basically, that's how I ended in a medical school. When I look back to medical school, many years ago, actually, I started medical school '81, and now it's 2022. So basically, what was important when I look back with the distance to the medical school? First, issue I wanted to emphasize, that preclinical science, and you're struggling now, actually you're starting to struggle with preclinical science, with biophysics, physiology, biochemistry. To me, it didn't make any sense when I was there. Huh? I said, why do I need that? I'm going to be a doctor, so why do I need that? Huh? But looking back, it's crucial to understand the disease and principles of treatments. So when you learn this, you will forget 95% plus. But it's an essential step for you to understand the disease, the pathophysiology of the disease, and also the treatment. As a student, always combine theory with clinical work. So spend as much time as possible with patients. Learn from patients, because that's how you will become a doctor. And very important, get impression about medicine in other countries, already in medical school. So I did student practicum in Germany during 2 summer breaks. I also worked as a nurse there. Of course, at that time, this was still former Yugoslavia, and I wanted to make some money, so I worked as a nurse, and it was very, very well paid, because we were very poor in former Yugoslavia, which was part of Eastern Europe. And also, I spent some time as a part of medical team in Catholic mission in Kenya and Zambia. So African medicine, where you really see what is the poor country, how people are poor, that the life has no value, and then you can better appreciate what we have here in Europe. And try to get exposed to research already as a student. So I did student research during the 4th and 5th year of medical school. And this is my student research, the serum enzyme activity in acute left heart failure. And here you see 2 nice graphs. So we had 27 patients. In 21 patients, at least one of them was increased. Well, when I look back to this work, and basically it was this lecture which triggered me to go back and look what we did in '97, there was no obvious hypothesis. Methodology of research was very weak. Data analysis and interpretation, very weak. And it was so what kind of research? So you find something, but it will never help a patient. And looking back, I mean, this could not have been published in a serious journal. But importantly, it was fun to do it. Something new. I need to think out of the box. I had to write my first research article and present the data. And I saw how very sick patients look like, because I spent a lot of time in intensive department. And I also met the staff, nurses and physicians. And this is really crucial for my further development. So I graduated from medical school April 16, 87. And I was very happy, of course. You will be very happy. But remember that this is only a start of a very long life journey in medicine, if you stay in medicine. And the next thing was how to choose a specialty. Well, you will face a dilemma, and you may choose a US salary pattern. So what is US salary pattern? Just look at how much do physicians earn overall, and then maybe draw a line and say, okay, these are the specialties I wanted to choose. I don't care about this, because I wanted to earn more. Well, unfortunately, this happens quite a lot in US. Of course, you can go a step further, and you follow funny algorithms. Here I have one of the algorithms. Medical student, crazy, sane, attention span, significant, psychiatry, non-existent, emergency medicine, sane, hardworking, whatever. If you like patient asleep, you go to anesthesia. I'm not going to discuss pathology. But surgery is interesting because it goes over being mean. So this is actually also a way. But honestly, my advice, get exposed to different specialties already in medical school. Find what fits you the best. Follow your dream field, regardless of the temporary availability and salary. Because remember, if you don't go to a specialty you are not in love with, because you will be unhappy. And treat my lips, the money will not help you. So I followed the algorithm and ended up as a resident, this is a specializant in medicine and intensive care. And I also started, because I was already infected by the research as a medical student, I also started a program for Master of Science, which is probably not existing after Bologna Declaration. But that was interesting. And basically, I did a work, we tested one of the antiarrhythmics in patients with some arrhythmias. And basically, it was very successful because it was published in American Journal of Cardiology, which at that time was a top journal. And there was quite a lot of citations. So it's very important that you publish in a journal which people read, and then if people read, they always also cite you. And that tells you how important is your research. If you don't get citations, then nobody cares about that. So that was a big success. But you know, looking back, I was very lucky because so many things came together and resulted in the top publication for that time. And this was really a kind of miracle because at that time I was still living in post-socialistic country of Yugoslavia, and this was probably one of the best publications within the whole country for many years. And I also realized once again that I like research, and I could spend my entire career as a full-time researcher. So not be a doctor, just to do research. Well, that's also an option. So I went to Chicago to do my PhD, and it was 91, where actually the war for independent Slovenia started. So the Federal Army attacked Slovenia because Slovenia wanted to become independent, and we had a war. And actually I was not sure whether I will come back or not, because I joined a very famous guy at that time, one of the pioneers of modern cardiac arrest research. And I spent there 2 years. And basically, I did only experimental studies. So this is a rat model of cardiac arrest and cardiopulmonary resuscitation. So this is a 500-gram rat, and this is a tamper for chest compression. So we had a model, and these are all the lines, etc. A very small model for cardiac arrest. And we also had another model, a peak model of cardiac arrest, and we did studies on cardiac arrest in pigs. And I remember one afternoon, every Friday afternoon, we had a research meeting where we discussed new ideas, look at the results, etc., etc. And then Dr. Weil came and said, why do we need to do mouth-to-mouth breathing doing bystander CPR? So 5 compression, 5 compression. Many people do not want to do this and therefore abandon also life-saving chest compression. And then I said, Dr. Weil, this is written in international guidelines. And he became very angry. He said, Marko, we are researchers. We are looking for scientific truths, not for recipes. Show me the evidence, show me data. Go to library, I give you 2 days to find the evidence, to find the paper showing that you really need to do mouth-to-mouth ventilation. I said, okay, we'll do it. I thought there would be no problems, and there will be plenty of studies showing that this is essential. But in fact, there was nothing. So I sadly came to his office, said, Dr. Wild, there's nothing, huh? And he said, okay, go ahead, now design the experiment. And then we did first animal experiments on chest compression, only cardiac arrest. So no breathing, just chest compression. And we did in rats, rat model of cardiac arrest, which I showed you. And there was no difference in resuscitation. And we moved to a pig model showing no difference in resuscitation. Well, it doesn't look like we need mouth-to-mouth breathing according to these animal experiments. And very importantly, we got independent confirmation of that by another investigators who also did these studies in different animal models. But it took 7 years to the first human trial in 520 patients, showing no difference if you do only chest compression, so even better survival. And another study showing also even better survival if you do only chest compression, only cardiac resuscitation as a live bystander. So situation today regarding mouth-to-mouth ventilation, chest compression only as a part of lay basic life support was finally recommended by major international guidelines. So CPR today is much more straightforward. Chest compression, call, compress, use the defibrillator. Because by eliminating rescue breathing, this algorithm, as I said, was very simplified, and more live people nowadays perform life-saving chest compression. And looking back, I was very lucky, actually, to be part of this research story, which translated really to clinical medicine. Because this is the ultimate goal if you do research in medicine, that by the end of the day, the patient benefit. But, you know, I'm aware that I was just lucky. I was at the right time at the right place and got that project, and, you know, we found the scientific truth. We also investigated, so this is the signal of ventricular fibrillation. This is cardiac arrest. And this is electroshock. And here you see normal cardiac rhythm again. That's how it looks, cardiac arrest. So investigated the also characteristic of this signal to predict success of shock. And we found again that if you don't reach sudden amplitude and sudden frequency, you will not resuscitate the peak in this project. And this actually became US patent incorporated in automated external defibrillators, which you know, I'm sure, very well. So Chicago was very successful. So I got a lot of publication because I was really lucky with the research. The group was very productive, and I learned a lot. I learned research methodology, data analysis, scientific writing. I also learned how to present research and how to answer questions. So if you ask me questions after this lecture, hopefully I will know how to answer it well. And I learned also how to defend results if they are in contrast with common fate. So it was very difficult to defend in the scientific community that you don't need rescue mouth-to-mouth breathing. But, you know, we just believed that our methodology was right and that we found scientific truth. Research is based on honesty. This is very important. Because if you're honest, if you report the data as they are, if you get good methodology, you will get scientific credibility only if independently confirmed, if your results are independently confirmed. Remember, if you lie, this will not happen. Nobody will confirm you. How to interpret scientific research? how to read papers without spin doctors, how to look at methodology by yourself and data, look at the standard deviation, statistical methods, etc. This is everything what you learn, and you will benefit from that as a researcher, not only as a researcher, but also as a physician. And I'm going to show you that. And why it's important to know clinical practice if you do research in medicine. Okay, you decide I'm going to be full-time researcher my whole life, but you don't want to do unnecessary research. Because you don't want to get published in journal of unnecessary research. So you have to address relevant clinical problems, avoid research without any translation potential to clinical medicine. Because, as I said, ultimate aim of medical research is to improve outcome of sick patients, which you will be treating. And not to get published, to get points for promotion, to get famous, gain financial support, make medical industry happy, become rich. If you're honest as a researcher, you'll never become rich. But after Chicago experience, I remained financially poor, but scientifically very happy. But also I loved research. I did not imagine my career without clinical work with patients. So I said, okay, I did 2 years. It was very successful, but this is not something I can do my whole life. And I would never know that if I haven't tried. So I returned back to Slovenia. Here you see the city of Ljubljana with the nice castle. Maybe some of you have already been to Ljubljana, to Slovenia. Was anybody in Ljubljana, in Slovenia? Okay, good. So you remember the castle. And you know, I was back, 93, and the war was over at that time. Slovenia became an independent country, and the future was very bright. So I went back to clinical arena and focused on acute myocardial infarction. So this is how the patient looked like. You know, chest pain, chest discomfort, severe. And I'm going to show you how it looks in the coronary artery, which is the target and the culprit. So here you see the flow in coronary artery. And here you see the process of coronary atherosclerosis. So these are the plaques. But here the patient doesn't feel anything. And then suddenly, out of blue, this plaque may rupture. You will see that here. And all this content come in contact with the blood, and then the whole process of thrombosis started. So this is the blood clot, which actually forms on top of the ruptured plaque and grows, and completely closes the coronary artery. And of course, the heart from here on does not receive any oxygen, and the process of acute myocardial infarction started. So this is what's going on here. One of the coronaries is occluded acutely, and this patient has severe pain, and if we don't help him, it's very likely that he will die. So we can, of course, since this is clot, we can dissolve it with special drugs which are called thrombolytics. And in our department, we actually started, my colleagues started 82, reperfusion. So this drug was successful only in 52%. And mortality was still very high, 12%. And another option, which is much more effective, is so-called primary percutaneous coronary intervention, PCI, which is a superior alternative. So you see here the occluded coronary artery. So this is actually, if you remember that video, this is when the thrombus occurs. And then we go with the catheter and special wire across this clot and put a stand. And in almost 100%, we restore the blood flow. So this is after. So we started here, and this is after. And when we restore the blood flow, of course, we interrupt the development of acute myocardial infarction. And the patient has much, much higher likelihood of survival and much better quality of life. And actually, this method was first used in Slovenia in September 18, 1989. So here you see the occluded coronary artery, and this occlusion was potentially fatal for this patient. And then they put first lytics here, and since they were not successful, they dilated this lesion with the balloon. So they went from femoral artery with the catheters, put the balloon and opened the coronary artery. And this guy really survives uneventfully and also lived long term. But this happened actually only once because he was a VIP patient. And this was done only for him. So this was still former Yugoslavia. We were all equal, more or less. But this was, from medical point of view, it was a big success. From the moral point of view, it was a failure because this did not happen for many years afterwards. And it was actually Professor Vidimski's visit in Ljubljana which triggered primary PCI. It was 97, and he visited us. I was attending his lecture and got very impressed. And that's how we started our PCI program for acute myocardial infarction. And he also inspired me to move to the interventional cardiology, which I showed you. But of course, these are skills, and you have to learn. You have to learn from the right person. Because if you learn from wrong person, then you will be doing same mistake with more confidence. So whenever you go and try to learn a complicated medical skills, you always have to learn from the best. So I went back to America, this time to Los Angeles. And now I said, okay, now I do clinical fellowship. So no more animal research. I just wanted to learn this stuff. So Dr. Sersek, my good angel, actually, he was my mentor probably for my whole life, helped me to get this position because he was chief of intensive care here. And I also got very strong recommendation from Dr. Weil because I was there for 2 years in Chicago, quite successful, and he called, said, yeah, take this guy. Huh? That's how it goes, And I had to pass USMLE exams to get a medical license. So one advice to me would be also during medical school, try to pass these exams. Because it always, even if you don't use it, you will get much more confidence that you're certified also in US, or maybe if you go there for training, it will help a lot. And during medical school, you can independently test your knowledge. And actually, I was also very lucky at that time to meet Professor Ganz. You will meet famous Swan-Ganz catheter. Professor Ganz actually was born in Slovakia, and he worked, I think, at your university. No?
He was working with my father.
Okay. Okay. So, world is small, Peter. So actually, he was a legend together with Dr. Swan, and I met him at that time, and he attended that seminars, etc. we had. So it was so spectacular to meet him. And every fellow, and you can see that's me with much more hair, obviously. A dream of every fellow was at that time to get Swan-Ganz sandwich picture. And that's actually what I got. And it's really a nice memory because they were really giants in medicine. So I'm coming to Czech Republic again, already second time. So at that time, so I was there for 2 years, high volume cath lab, so a lot of interventions, excellent operators and teachers. They had already primary PCI program in place, which I wanted to introduce in Ljubljana. And actually I did quite a lot of interventions because I was there day and night. I was alone, not married. I loved medicine. I was married with medicine actually. Had a lot of time. So instead of, except for oral bleeding in Santa Monica every Saturday, I did interventional cardiology. Even though I said I'm not going to touch research because I wanted to focus on, interventional skills. Actually, I was involved in the research at that time, but this was purely clinical research. So again, it was very important when I look back to combine practical work with clinical research. So research actually was beside me all the time, even though I was a doctor, primary. And as I said, what I learned is that if you want to learn more complicated medical procedure, learn it from the best. So go to the place where they are really good, because if you learn well from the scratch, this will be a credit, an investment for your whole life. It's worthwhile to spend some time and learn well. And when I came back to Slovenia, we started with primary PCI network for acute myocardial infarction. We had 2 interventional centers, and all patients actually were sent to one of these centers. So instead of thrombolysis, drugs which were much less effective, we wanted to open these coronaries, like I showed you. And there was a strong resistance by many colleagues, because it was new and basically is out of their zone of comfort, and they don't want to change. So it's very important when you go with new things, you have to be persistent. You don't give up. Because at that time, randomized trials, which are the golden standard of evidence-based medicine, were not available. And again, Professor Vidinsky provided me constant support. We met many times on different meetings, and we discussed, and it was reassuring for me that that you are going right direction. So Peter, thanks again. And my Cedars-Sinai, my American mentor, interventional mentor, said when I complained to him, oh, it's so hard. I mean, I don't understand these people. They keep, just going against me, etc., etc. So he said, it will be easier after you publish your results. And actually that's what we did. We look at the thrombolysis patients, 95, 96, and compare them with first 5 years of patients undergoing primary PCI. And you see a difference in mortality, 6.2% here versus 16.4%. So 10% less mortality when we did primary PCI. Of course, percentages doesn't mean much, but if you translate that to human lives, and if we have 800 STEMIs per year, 10% mean 80 lives saved per year. That's a lot. Because this could be your father, this could be your uncle, this could be, whatever. It's a lot of lives. And since we started this program so early, by the help of Professor Vidinsky, he also has a lot of credit for many lives saved in Slovenia in patients with acute myocardial infarction. But we went further and we said, okay, now we have this network, we have to upgrade it. And we said, okay, out of hospital cardiac arrest, this is the worst condition. Patient is walking, falling down and dies if there's no help. And this is the most common way of dying in the Western countries. So we said, okay, we will centralize also the treatment of these patients and treat them more effectively. So as you can see here, we started with temperature control, we increased coronary, we increased PCI, which I showed you, some mechanical support to the heart. So much more intensive treatment from 2003 to 12 than before. And there was a huge difference in mortality. 27% survival here versus 47% survival here. So again, 20% more patients survive with good neurological outcome. And then we went further and we went to percutaneous venous arterial extracorporeal membrane oxygenation, so-called ECMO. You probably heard for ECMO during the COVID or before for the flu. That was 2009, 2010. So this is actually a method which replaces the heart and lung. So how do we do that? From femoral artery, we put one cannula in femoral artery, another we put in femoral vein, another we put in femoral artery, and we are taking venous blood, sending through the device, and sending back to the body. And we again centralize care for these patients and really make possible 44% of patients who are really in severe cardiogenic shock to survive, and 29% of patients who are essentially dead, the heart was not beating. We resuscitated the heart with this method, and they survived with good neurological outcome. And again, going back to Czech Republic, we were inspired by Jan Belohradek from Prague, who's really one of the pioneers on this field in the world. And this is actually probably one of the best moments in my medical career. Because here you see, these are our ECMO patients. And we organized the height of ECMO survivors from Planica to Taman. It's about 1 hour walk. And I walked together with these two guys. And these were both ECMO patients where I put them on ECMO. So basically they were essentially dead, but now we were walking together to Planica for 1 hour. And this is really what counts in medicine, the patient outcome. If somebody is very sick or almost dead and you bring him back to normal life, this is really the best what can happen in medicine, at least for me. So basically, our network, acute myocardial infarction, evolved to acute cardiac network, which means for all acute cardiac conditions. So acute myocardial infarction, cardiac arrest, ECMO, which I showed you. And very importantly, we publish results, outcomes regularly. This is important because people see that you are doing something. You can compare results with others. Others can compare results with you. And once you publish and other, again, independently confirmed, you become, you get a place on international map. So people know, okay, this center is doing this, and they are doing very well. And now, going back to research, how did my research help in development of our acute cardiac network? Well, I learned research methodology, etc. And also important, Dr. White told me, if you lecture, you will always know the literature. Because when you lecture, you have to read and to be updated. And I still remember so well when he told me, never accept a lecture if you don't have your own data which provide you with the scientific credibility. So I will not lecture, I cannot lecture about hematology, I cannot lecture about congestive heart failure, but I can lecture about the things which I did research and we have our own data. And of course, I learned interventional cardiology at Cedars-Sinai. Through international academic career, I became good friends with many experts. Very important. I mean, this is really what is really the key if I look back. Informal debates with the experts while having a glass of beer. So basically, it's not the meeting, but afterwards we met and we had the beer and then we discussed, and then you get new ideas, dilemmas, you see other experience honestly, and also obstacles and solutions. Also very important to get involved in international trials, because everything will further improve your clinical care for the patients and generate new research ideas. And now let's go to the clinical arena. My thesis is that every patient is a unique research project, because diagnosis is really the key for the treatment and prognosis. But diagnosis is a hypothesis, and you need to confirm hypothesis or reject by patient history, etc., etc. And then treatment. For every treatment, we have to know whether it makes a difference. Does it make a sense? If it doesn't make a sense, you don't want to do that treatment. Whether it's improving only, either it's improving survival or also symptoms. So somebody lives longer and has no pain and breathes normally. And we also know for each treatment complications and side effects. And then when we apply treatment, we have to monitor, evaluate response, and modify treatment if necessary. Document the outcome and develop registry and analyze outcomes. And if you look at typical patient, 83-year-old patient with shortness of breath and collapse, there are many like that. Diagnosis hypothesis, severe aortic stenosis. This is narrowing of the aortic valve. Need to confirm, reject, patient history, echocardiography. Define the stage. We have parameters to define the stage, how severe it is. And then treatment. Percutaneous dilatation of aortic valve. So we go through the femoral artery into the aortic valve, we don't open the chest. Level of evidence, very strong, because there are many studies showing the benefit. This treatment improves prognosis, so patients live longer and they live better. Complications, side effects, rare but life-threatening. Now let's see this patient. So this is a picture of aorta with this stenotic valve here. So this is a catheter and we are injecting the contrast. And then we put the valve, you see the valve. And now, instead of stenosis, the patient has good function of the valve and he's fine. And we didn't have any complications. But as I said, we have to analyze outcome and compare it with standard of care. So this is my series, 372 patients, this study. And this is the Kaplan-Meier curve of survival. So for each year, we show the likelihood of patient to survive. And these are the confidence intervals. You will probably learn that maybe already in the first year in the statistics. And these are the data on mortality, the percentage of mortality each year. And these are the major international studies. And you see that these points are actually lying within the confidence intervals of our data, which means that we are doing internationally well, that we are there where we should be according to international standards. And it's also very important to analyze complications. This is so-called mortality morbidity conference. So if something goes wrong, you don't hide this. You never hide this. You have to openly discuss. And this is very important point because many people just don't want to talk about it. They hide and they repeat the same mistake. Somehow to do mortality morbidity conferences, I learned in the States because we had that after every complication. The aim is, as I said, not to punish the operators, but but to prevent complication in the future. And we wanted to see whether this was a mistake of the operator, wrong judgment of the operator, or just bad luck. And conclusion is to answer the question, what I would do differently if I had another chance. So I had, among these patients, 372, 6 per-procedural deaths. In one patient, wrong measurement by valve company, and I didn't recheck. I should have rechecked. 2 patients, operator mistake, wrong judgment during the procedure. 3 patients, bad luck. I would not change the procedure if I had the chance to do it again. And these 3 deaths will hopefully be preventable in the future. And this is just the biology and statistics, and cannot be prevented. And this is part of our job, because nothing is 100% in this, except for birth and death. So final take-home message for you as medical students in the medical school here. Knowing of research methodology, I showed you that, my work was really, connected all the time with the research work, either preclinical and clinical. All this together, I'm sure, make me much better physician. And, of course, this is good for patients. What's really important, my advice number 1, as I said, obtain research experience even though you do not plan to stay in academic medicine. So even if you wanted to work in a private practice or whatever, as a student and then as a resident and fellow, you should get involved in research, because that will help you through your whole clinical career, even though you will be just clinician and you will not be doing academic medicine. Advice number 2, if you plan to do full-time research, said, okay, I'm so interested in research, I will not do clinical work, but I will focus my whole life on research. I wanted to do something new, I wanted to get Nobel Prize. Very legitimate. Why not? Everybody can get it if you work hard and if you're lucky, and if you're in the right place. But if you wanted to go this way, so to do full-time research, always keep your eye on what's going on in clinical medicine, because otherwise you will be investigating things which are not important for patients. So it's very important to have a sense what's going on in clinical medicine in order to focus your research on the right things and not to get published in the journal of necessary research. So with that, I would like to thank you for your kind attention, and really I wish you all the best in your medical school. I wish you successful careers. I wish you that you find a spot in medicine where you will be the best. And remember, medicine is really probably the best profession available. Thank you so much for your kind attention.